Welcome to RetinaRA.org, a Vitreoretinal knowledge-sharing platform. This video will present a Tractional Lamellar macular hole surgery. I am Dr. Giray Ersoz, the co-editor of RetinaRA.org. The invited operating guest surgeon is Ayşegül Mavi Yıldız. Her Instagram account is @AysegulMD. This is a 54-year-old female patient whose left vision has been decreasing for the last 6 months. OCT revealed a vitreomacular traction, a tractional lamellar macular hole, LMH, a thin ERM at the edge of LMH, and a thick fibroglial tissue. The surgeon performed a combined vitrectomy with cataract surgery in this case. She used the IBOS 2 imaging system and the DORC-EVA phaco-vitrectomy device. After the single-piece foldable IOL was placed in the capsular bag, the corneal entry sites were closed with hydration. No corneal sutures were placed. She placed the 23-gauge trocars in 2 stages. First, a core vitrectomy was performed. The infusion was then turned off and triamcinolone was injected. The infusion was then turned back on, and the posterior hyaloid was observed to be adherent to the fovea. Therefore, instead of applying a direct posterior-anterior force on the optic disc, the surgeon first released the posterior hyaloid around the macula and then dissected the entire posterior hyaloid. The surgeon's goal was to prevent a full-thickness macular hole from developing due to fibroglial tissue adherent to the fovea. After the infusion was turned back off, brilliant blue dye was administered over 45 seconds. Note that the surgeon injected the dye very slowly when close to the retina. Injecting the dye too high in pressure near the retina would result in toxicity. The infusion was then turned back on and the dye was cleaned. The ILM was peeled off in a controlled manner using ILM forceps in 2 optic disc sizes. As I mentioned in the previous videos, there are 2 things to be careful about to avoid creating a tear in the retina during this time. First, when the shadow of the forceps on the retina and the forceps are aligned, you are right on the retina. Second, the retina is a transparent tissue, and the pinkish-red reflex we see belongs to the retinal pigment epithelium and choroid. If we try to hold this pinkish-red tissue, we will damage the retina. At the end of the surgery, first, fluid air exchange was applied from a place close to the optic disc. To make sure that the fluid was completely aspirated, the surgeon waited a few minutes and then applied aspiration from the same area again. After an air, 5% C3F8 gas exchange, air was infused into the anterior chamber. The surgeon routinely performs anterior chamber air infusion for IOL stabilization and gives mydriatic drops in addition to the prone position in the first postoperative days. 1 month after surgery, foveoscosis or LMH disappeared and a complete foveal depression occurred. The patient's visual acuity had improved to 20/25. The absence of refractive error also proves to us that the IOL is centralized. Thanks to the postoperative autofluorescence image, we understand that there was no damage to the retina during the peeling.
You can share your interesting and educational cases on our website RetinaRA.org. Don't forget to click the like button and follow our channel to be informed about our new posts.